Good day, everybody. We start in 23 minutes. Here I come. How are you guys doing? I'm John Bennett of Neurosurgical TV. Is there anybody out there? We're actually on YouTube and Zoom, but we're not live. So does anybody want to say hi? I think you'll get less shy and use this platform as networking to meet the other neurosurgeons around the world. And we'll use it to introduce themselves because Juha is very approachable. You guys should try talking to him. And it's your chance to. The world is changing. Man, when I was a med student, it was hard to have any time at all with one neurosurgeon. For 4 years, here you can talk to him casually. And here's Juha now. Talk to him. Hey, Juha.
Hello, John. Hello, everybody.
Yeah,
How is Miami? How is Miami Beach?
We televised you last night from Bogota.
Yes, it was early morning here.
Yeah, we got that. That's a pretty big. That's a 3-day conference. Pretty big.
Yeah, I just gave my lecture. I couldn't follow them because there's awkward times for us. But
Yeah,
I have seen in internet and Facebook. I have seen some of the lectures. Yeah.
Yeah, I was surprised. I just accidentally stumbled on it. Matter of fact, to televise Dr. Goel's talk, but I never caught his talk. Did you catch his talk?
I wanted also to follow, but there was some other talk beginning, so I couldn't wait any.
I don't know if he did talk. I don't know if there was, because I seemed to miss him. I thought, wow, where would Goel go? I thought he was supposed to talk, but anyways, how's it going, Juha? Does anybody want to say hi to Juha? This is valuable time.
Everything is okay. So
things are stable,
not
right?
yet many there. So it is.
Yeah, not many people are traveling to China now, right?
No, it is. There's a 3 weeks quarantine.
3 weeks, so you have to stay there.
You cannot go out when returning, so you have to be 2 weeks at close to the airport in quarantine, then 1 week at home, 8 days.
So it's hard to go to a conference because it's a 3-week commitment.
No, you cannot go. It is. I have been 6 weeks last year. Beginning, I was 6 years in quarantine, so it was enough. Sealed door, and you cannot go out, so it is extremely hard.
Really?
So this
prevents
every traveling.
Still
prevents every traveling.
Oh, really?
Yeah.
Here it's opening up a little bit. Less masks, less restrictions. And a lot of places kind of are on the honor system about vaccinations. So, you know, if you've been vaccinated, you don't have to wear a mask, etc.
Mm-hmm. Yeah, here in China is extremely strict. There are maybe 5 new cases somewhere, and the whole country is in alarm situation. Yesterday, when going to hospital, so it was so strict control, and
yeah, you know, I sense Latin America is easing up a little bit, as is India.
Yeah, India is a neighbor country here. India is in flames, and Nepal also. So
Okay, Jay, well, we'll talk later about the schedule.
yeah, about which schedule?
Yeah, I think that James Leo was asking, because he was,
June 18.
yeah,
He will
yeah,
be on. So
yeah,
maybe next week. Then we have one Friday. We have free because I proposed June 11th, but
oh,
he
yeah.
was busy that time. So we take him June 18th. So we have
Good,
to ask.
good, because he had a
One
commitment.
place June 11th is free. Almefti will be next Friday, June
Okay.
4th.
Okay. Yeah, he had a commitment right after, and there was a time squeeze.
So we are waiting for some important people. So Michael Lawton, Subin, or Liao is here for translating.
Okay, Dr. Liao, is Dr. Bin coming? Is Bin coming? Or-
It would be good for discussion if Subin would be there.
Okay,
Liao is
Hello,
here.
Professor
He's also
Juha,
bypass
Professor Joe.
specialist, so you can go on with
Hello.
the discussion with Michael Lawton. So I think it is better because you are bypass specialist, so you should lead the discussion.
okay,
I will give a short introduction in the beginning, and then we go for Michael Lawton's
okay.
lecture. Getting awake. This very early. It is 5 o'clock in Phoenix, I think.
Oh, yeah. Yeah, it's 8 o'clock here. It's 2 hours. I think it's 6 o'clock there. I think it's 6 o'clock.
6 o'clock.
Hi.
Good morning.
Hello, Victor.
Good morning.
Hello. Good morning. Hello.
Hello,
How are
Professor
you?
Juha.
everybody.
I am glad to see you so much. To you,
Thank you very much. Hello, Takashi.
Professor.
Good morning, Takashi.
Oh,
Hey, good
Hello,
oh,
Takashi.
Mash. I am very glad to see you.
Thank you. Where are you
You
coming?
so
Where are you?
fantastic.
Thank you. Where are you?
Oh, I am
Dilbrot,
from
where are you?
Uzbekistan, but
Uzbekistan. Okay,
I am
okay.
but I am working at Yemen for getting experience because here civilian war have more cases for getting experience.
You need trauma cases, trauma experience.
Yeah, that's trauma there.
Yes. For starting, not bad. For starting, getting experience, not bad. Trauma cases, step by
certainly
step, everything.
Gunshot injuries, many cases.
Yes.
Dr. Juha.
Yeah, Victor.
We would like to know if you could give us a lecture in next month by webinar about aneurysm of the basilar tip surgical treatment. This is for the College of Mexican Neurosurgeons. It
Of
will
course.
be on June 22.
Yeah, just send me a WeChat message, so it will remain in my mind. June 22. It's okay. It's okay.
Yes.
We will do.
Thank you,
You
Dr.
know,
Juha.
do you have WeChat, Victor?
Excuse me?
Victor has
I have.
WeChat. Yeah.
Yes, by
You,
WeChat.
you have it, Victor?
Yes.
Okay.
Yes, I have
Shubin
it.
is here. Shubin is here.
Yeah,
Welcome, Shubin.
Michael's here
Hello.
too. Michael's here too.
Okay.
And we can start
welcome.
right away. We can start right away, you are, because Michael's always tight with time. Do you want to start right
Yeah.
away?
Yeah. Is that
Yeah,
okay
okay.
for Michael?
Yeah, okay. Yeah, I
I
think
cannot.
I'll see if Michael is okay with Michael.
Is
Good morning, Dr. Lawton. Are you there? Good morning, Ben.
Hi.
Uh,
Hi, John.
How you doing?
Thanks,
Welcome,
Ben.
welcome.
Hi. Hi.
After Michael's lecture, can you lead the discussion on the
Okay.
you're certainly the man to discuss.
Okay.
Yeah. Can you do that with your
Mhm.
experience? So
Mhm.
it's different than mine.
Yeah, Michael was here. I don't know where he went. He might have
I
dropped
see
off.
his name.
Michael, are you here?
He's muted.
Okay. We done last minute business. There he is.
Okay.
Hey, John.
Hello, Michael.
Hey, Michael.
Welcome.
Hi, Juha.
Good morning there.
Good morning.
Good morning. Yeah. Hi, Michael. We'll start right away, okay? Because you always you have a time crunch, okay?
Yeah,
Here-
that's always true. Hold
Yeah,
on,
here
let me
we-
just,
Okay.
I just
Is
need
that
to
okay?
find
I
my,
will give a short introduction and then you will give your webinar lecture. Is that okay?
okay.
We go.
Hold on one
John?
second. Let me just get
Okay.
to my talk.
Okay.
I will give a short introduction. Maybe during this time you can find your lecture.
Okay. All right, I found it.
Just-
Hi. Good morning, Professor Lawton.
Good morning.
Are we ready to go?
Yeah, I'm
John,
ready.
John?
Yeah,
I
you
will
ready?
give a short introduction.
Okay.
John, your Miami Beach is counting.
Okay, hold on. Let Michael get. Okay, you ready, Michael? Okay. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good
Great.
morning from Miami Beach. It's Dr. John Bennett for Neurosurgical TV. We're graced with the presence of Michael Lawton, and we'll start right away with Juha. Could you please give a proper introduction of Dr. Lawton? Go ahead, Juha.
Okay. Hello, Michael Lawton. Dear colleagues, I give a short introduction. So Professor Michael Lawton is working now in Phoenix, Arizona, USA. He's the chairman of Barrow Neurological Institute. He's certainly one of the most important neurosurgeons of these times in the world. He became medical doctor 1990, and after that he was a resident at Barrow Neurological Institute 91, 97, under legendary Robert Spätzle, and then he moved to
1998年から2017年まで行ってると。で、現在、BNI の新しいリーダーとして、2017年から勤務されておられます。
John, can you take minutes? Can you manage that? Then he moved to USF.
それから、レジデントがスペッツのところでやって6年の後に、
I'm sorry.
University of
Let me
South
get
Florida
that.
ですね。
Hold on.
Translation is coming here.
Yeah.
Japanese
I-
translation.
yeah.
Okay, then he moved to USF and
USF に移り
made
まし
a
て、
very intensive cerebrovascular practice
非常
there.
にインテンシブ
Operated
な
months of
手術と
cases
臨床をやられました。
and was elected as
それで、
new leader at Barrow Neurological Institute.
バローニューロジカルインスティテュートですね。
Takashi,
2017年から、はい。
Translation
okay.
is coming through.
Sorry.
So, how to become a good neurosurgeon? I never saw a person who wanted to be a bad neurosurgeon. There's many good role models. Train hard, follow the way Professor Michael Lawton has done, is doing. There are different levels of manual skills, and mainly they are dependent on the number of repetitions and length of career. There is the old rule that with 10,000 hours of training, you will come to the world top. And my rule is that with 10,000 days in operation room, you will be at your best in your neurosurgical career. Neurosurgery has three parts: operative skills, research, clinical and basic research, and teaching. And Michael Lawton has been teaching all the world with the 7 series, 7 aneurysms, 7 AVMs, and 7 bypasses. And he has also published more than 700 publications, including important textbooks. Until now, he has done amazing more than 5,000 cerebral aneurysms and 900 AVM operations, and more than 1,000 cavernomas, 250 of them in the most difficult location in the brainstem. And what is important, he continues his hectic practice. To have that kind of numbers, you have to be excellent neurosurgeon, organizer, surrounded by a good supporting team, and the patients and society, and to have a big population. Barrow Neurological Institute is the model for all neurosurgical institutes in the world. You should visit when the world opens there. But this is important. You should train your best young people. They should become better than you. My teacher, late Professor Drake, was saying, if we cannot find that kind of people, then we wait. One day they will come. And at Barrow, you certainly have found huge number of these people who want to become better than the older generation. So this is the introduction for Professor Michael Lawton, short introduction because he's so famous and well known. He will speak on the 7 bypasses, and after the lecture, Subin will lead the discussion. So go on, Michael.
Thank you, Juha. Can you see my title slide and can you hear me okay?
Yeah,
Yes.
perfect. Perfect.
Okay. Well, Juha, it's always a pleasure to see you. You look well, and it's so nice to see that you've found a home to continue your passion. Well, it's early for me in the morning here, so hopefully I don't sound too delirious, but I want to talk about bypasses. I think for those of you who have an interest in bypass surgery, this will be hopefully an interesting talk for you. But even for those who aren't interested in bypass surgery and don't do bypasses, I think it's sort of a metaphor or a lesson in how maybe you should try and put your own practice together. In line with what Juha was saying, all of us want to become good neurosurgeons, maybe even great neurosurgeons. And the theme of this lecture is this is a path towards how you can do that, not just related to the topic of bypasses, but with surgery or neurosurgery generally. So this is my case volume at last update. You can see that I've been able to focus my attention primarily on vascular with my aneurysm, AVM, and bypass and cavernoma practice. And you know, one of the things that's been hardest for me lately is this curve to the right. If you look at my aneurysm volume over time, it's steadily climbing, and I've reached 5,000 aneurysms. But if you look to the curve on the right, what you see is that we've peaked. And despite all my efforts to write papers and to do good work, I have a practice in aneurysm surgery that's shrinking and not growing. And that's very discouraging. It shouldn't be that way. And one of my reactions to that is to say, well, we need to capture all that we've learned with all of these cases that have been done. And the way to do that is by writing. Writing is one of the ways that we become better neurosurgeons, because it allows us to synthesize all the things we've learned. It gives us time to introspect or to look at all of the lessons learned. It allows us to be creative. It's a frustrating process. It's a lonely process. But in the end, I've come to this belief that it's by writing that we really grow ourselves. And the pen is mightier than the scalpel, which means you can be the best neurosurgeon in the world. But if nobody knows what you're doing and nobody knows the work that you've come to or the ideas that you've come to, then all of that work is for naught. So writing has become a passion for me. These are my 7 books in the 7 series. And I started with this one because of that curve. I wanted to try and capture those lessons and preserve the art of aneurysm surgery. The 7 referred to the 7 most common aneurysms. And my feeling was that if we could preserve all of those 7 and were competent in those 7, that we would be able to deal with the vast majority of aneurysms that walk through our emergency room or our offices. The other idea was that the process of these surgeries could be simplified into steps, choreographed steps, just like a dance. And so dancing became the metaphor. The artwork with my illustrator then, Ken Probst, was like dance steps, numbering the different maneuvers and walking through the process, breaking it down piece by piece. So these were some of the illustrations. And for a middle cerebral aneurysm like this one, you could really understand the operation by going from number 1 to number 2, gaining proximal control, number 3, as you step up the M1 segment here, and then progressing to the other steps, finding the frontal division, working your way down to the aneurysm neck, working across to the other side where this inferior trunk is often hidden, and then figuring out how to place your clip. So that was sort of the idea behind this. And when it came to the more complicated aneurysms, like the giant aneurysms, what I began to come to was that giant aneurysms were very different. Giant aneurysms were something that were not just like a large saccular aneurysm. They were a completely different entity. And I'll show you this case. This is a woman who had this giant middle cerebral aneurysm. I clipped this with a picket fence, and you can see here post-operatively how it looked fine, but at 5-year follow-up, the aneurysm had grown back. So here we are at 5 years, the dysplastic tissue at the base had resulted in a regrowth. And so to fix this, I needed to do a bypass. I put in this high flow bypass. I then took the trunk off of the aneurysm and swung it over. And I created this, what I call a middle communicating artery that joins the frontal and temporal trunks, allows me to distally occlude the aneurysm. And now we've completely reconstructed the circulation distally. So here now is what that aneurysm looks like 5 years after my initial clipping. This is a view of the cervical carotid artery. So we've got an aortic punch here in the external carotid. We do a nice implantation of the radial artery graft. We tunnel it up back to the Sylvian fissure. And now this is the temporal division here on the temporal side of the aneurysm. So this distal end of our graft is being sewn in end to side. And normally when you finish with this anastomosis, this stump here becomes just a dead end. But if you think about it differently, if you repurpose that as a new donor artery, then you can take it off of the aneurysm like I'm showing here. I'm trapping it, I'm transecting it, and I'm going to now move it over to the other side, to the frontal trunk. So this dead end now becomes a live donor. And so we can reimplant it. This is now creating our middle communicating artery here, where the artery, this is the inside suture line, the artery swings over to the other side. It feeds both this artery here and also receives the flow from our high flow graft. And now with those two bypasses in place, we can now complete our distal trapping, which is with this second clip. There were lenticular strides, so I couldn't completely trap, but now you see our middle communicating artery and a nice reconstruction of the aneurysm. So what this case shows you is that you can clip giant aneurysms, but they're very prone to other problems, in this case, recurrence. And instead, if we think about these as a different entity, we realize that we need a different strategy, and that strategy is bypass. In my giant aneurysm series, which you can see here on this slide, the numbers of bypasses for the giant aneurysms is 44%. And now, now that I've sort of come to this way of thinking, most of these giant aneurysms, I begin to think of how I'm going to treat them with a bypass strategy as my first resort. So I'm going to skip my comments on this book 2 on the AVM surgery and jump or continue that theme about bypass with the third book here. And with the third book, my goal was to really elevate the art of bypass surgery. And to do that, I wanted to do a couple things. One was to develop a symbol or a system of symbols to translate bypass design into surgical constructs. And we really needed tools to capture our thoughts, capture our imagination, and translate. The second thing was to develop this taxonomy for bypasses, and that's really what the 7 bypasses was all about. And finally, to advance the intracranial to intercranial techniques. The ICIC techniques are ones we're all familiar with, but the ICIC techniques were where I saw the future. And so these were my objectives. And like with the other books, I needed a metaphor, and the metaphor was architecture. This is the Golden Gate Bridge in San Francisco, where I lived for 2 decades. This was one of my morning runs with the sun rising over the city. And this is more than just a bridge connecting Marin County with the city of San Francisco. This is really a statement about American engineering and ingenuity. This is 2 750-foot towers. This is 81,000 tons of steel suspended by these almost invisible wires. This is a beautiful construct. The cables going from one side to the other back and forth to create the strength of that suspension bridge. They're about nearly 90,000 miles worth of cable. And in the end, what you see is this beautiful statement about how we're able to span the waterway. And it's really, it could have just been a practical bridge, an ugly bridge, but it turned into this really majestic engineering feat. When we look in New York, we see the Freedom Tower, which has become a symbol of American resilience after the 9/11 attack. And it too is more than just office space. This is a statement about our resolve. This is the Basilica La Familia in Barcelona. And this is Anton Gaudí's creation, using parabolas instead of circular shapes, using these branched columns, these beautiful new constructs that had never been built before. And he was making a statement about what his vision of architecture should be. This is Jorn Utzon's Sydney Opera House, and you can see how he used these concrete shells and stacked them to make them look like sails on a ship, building this symphony hall out into the water so that it looks like a boat at sea. And here is Frank Gehry, again in Spain, in Bilbao, with these beautiful abstract forms, these titanium shells around this building that almost create the look of fish scales with this fish right in the water. So the point here is that these architects converted their craft from this practical thing of creating shelter into really expressing themselves and making statements. And I think, in neurosurgery, we don't often have the opportunity to do the same thing, but in bypass surgery, we do. And so we can transform our craft from plumbing to art. it becomes a form of self-expression, an expression of creativity and personality, passion, and something that really challenges us to achieve perfection. So that's really one of the key messages here is I think we can look at all of our practices, whether it's bypass surgery, tumor surgery, or spine surgery, and ask how can we transform what we're doing into something more beautiful or higher. Now, one of the things that was important not only for architecture, but for bypass is this idea of blueprints. This is the home that my wife Suzanne and I built in Phoenix. And to go from an idea of a home to the actual building of a home, you have to develop blueprints that you can work with the architect, capture your vision, and then translate to the team that constructs the house. And so the blueprint becomes a really critical part of that process to translate the idea into a home. And in bypass surgery, we really didn't have symbols. We really didn't have blueprints. And so one of the things in the book was to create this system of symbols. And this slide just captures that idea where on the left, we have symbols for the different types of anastomoses. We have symbols for the different types of bypass grafts. We have symbols for the different types of aneurysm occlusions. Over here on the right, we have the different circulations, the anterior circulation, the middle cerebral circulation, basilar circulation, and the pica circulation. And we can put these symbols together to capture our bypass. This is what we call the Barrow bypass coder. It's online on our website. If you have an idea for a new bypass that you've been thinking of, you can go to the site, you can drag over these different elements of the construct, you can put them on the diagram, and you can build a schematic for the bypass. And not only that, as you build it, it converts or translates it into the code, which I'll talk about in just a second. But you can see that this becomes a way to create those blueprints. So if you have an idea for a bypass, you can capture that and you can work out, the best way to put together this construct, what graft to use, how to connect them, what anastomosis you're going to use. And in the end, you end up with a schematic that you can share with your residents or your team and take to the OR. Now, that's the schematic way to express a bypass. But one of the other ways that you can do it is with code. And this is a paper that I wrote with Anna and with Al Lawton, where we completed this alphanumeric system for all of the different segments of the arteries intracranially. Dr. Lawton had done this nicely for the cerebral vessels, but not for the cerebellar vessels. So we finished it off. And in the end, we have this code where every piece of the arterial tree has an alphanumeric. And if we put those together in the form of a bypass code, you can see here we can capture all the different nuances that go into a bypass, which include the side, the donor specifics, the recipient specifics, the type of anastomosis that you do, which is captured within the parentheses here, the technique, whether it's a running continuous suture or an interrupted, whether it's intraluminal sutures or extraluminal. And all of this stuff gets captured in the bypass code so that when we look at a very complex giant aneurysm like this one, and we put together a bypass like this double reimplantation, we can capture it with this code. With just this string of alphanumerics, you can go to the operating room and you can know exactly how to perform this surgery with nothing more than just that. You can also do it with a schematic here if you're more visually inclined, but you can do it with the code, and it really clarifies the instructions, but also helps communicate what exactly you've done with your bypass. So this was all part of the process of taking bypass surgery and standardizing it in the way that we have with blueprints in architecture. Now, here are the 7 bypasses. On the top of the table, we have the EC-IC bypasses that use scalp arteries. Below that, we have the EC-IC interpositional bypasses like the high flow vessels or bypasses from the cervical carotid vessels. These next 4 are the IC-IC bypasses. Those are reimplantation, in situ bypass, reanastomosis, and the IC-IC interpositional bypasses. These are what I refer to as the intracranial to intracranial bypasses. And lastly, number 7 is the combination for any aneurysm where you need more than one bypass. This is a combination that brings any of these 2 together. Now, when you're trying to put all this together, we need a little bit more specificity on the aneurysm classification. So for this, as an example, these are all middle cerebral artery aneurysms, but some middle cerebral artery aneurysms are pre-bifurcation, some are at the bifurcation, and some are post-bifurcation. And if they're post-bifurcation, they can be sylvian, they can be insular, they can be opercular. So there are variations here. So it's very important to figure out exactly what type of aneurysm you're dealing with and classify it accordingly. Once you have it, you can then put all your different aneurysms across the top. You can put all of your 7 bypasses across the side here, and you create this menu of options for whatever aneurysm you're dealing with. You can go down the grid here and you can look at the different options that are available and make your choices based upon your options. I also put together these algorithms that can ask critical questions and help guide you to that final decision based upon, for example, whether it's a bifurcation aneurysm, whether it's ruptured, and how many trunks it has, 1 or 2 trunks. So here's an example. This is a giant aneurysm of the middle cerebral artery. As with all of these middle cerebral aneurysms, our first steps are going to be to split the sylvian fissure, to expose the anatomy. And here, our aneurysm is over here. This is the frontal division on the frontal side of the sylvian fissure. This is the temporal division on the temporal side. And you can see how these trunks are completely separated and require bypass. So for this one, I'm going to use the A1 anterocerebral artery as my donor. So it's all intracranial. The A1 is just to the side of the carotid terminus here. And so it allows us to use a donor that's right within our surgical field. It doesn't require a separate incision in the neck and a tunnel down to the neck. So here we're performing our arteriotomy. In the interest of time, I'm going to just jump ahead here. This is finishing up the anastomosis here to this back wall. And you can see that the A1 is an excellent donor because the flow is drawing right from the carotid terminus. So it's very high flow, and it gives us a very good donor source for the flow. Now, once we have that in place, we can take our graft up the sylvian fissure. We can run it alongside the frontal division. And with this linear arteriotomy, we can do a side-to-side reimplantation, or this side-to-side anastomosis that's going to join these 2 vessels. And that way, the graft can immediately donate to the frontal division. So you see here with our anchoring stitches, we're going to bring these 2 arteries together. You'll see this is a running intraluminal suture. So we're running right down the inside of both arteries here. And that brings our graft right next to our recipient so that the frontal trunk can immediately perfuse itself. So here is the second suture line coming down the outside with an extraluminal suture. And once that's in place, we can now readjust our clips. We can immediately perfuse that trunk with the graft. And you see how the other end of the graft can now continue on, and we can use that to go to the other side of the aneurysm. So this now is sewing it to the temporal division. This is an anchoring stitch. And what you'll notice here is this will be an intraluminal suturing technique. This is important later in the talk, but you'll see it's an intraluminal suture technique. Sewing on the inside, it allows me to shorten the graft to bring these together. And so this end of the graft donates to the temporal division. And you can see I'm just running that suture around from one side to the next. This is finishing up the intraluminal suture here. And we'll jump ahead. Now the anastomosis is done. We can come off with our clips. We can place our permanent trapping clips. The aneurysm is now isolated. You can see here, there's no flow in the aneurysm. There's good flow in the bypass. Our aneurysm over here is completely dark. And now we can deflate the aneurysm, completely dead, and the bypass is doing its job. So here is the final clip closure. I had to readjust the clips to save these little lenticular stripe perforators down here coming off the back of the aneurysm, but everything flows nicely here on the yellow 560. And here is an overview showing the bypass. So beautiful bypass, nice result for this gentleman, and an unusual combination bypass. So that's an example of how the code, the blueprints, and all come together to do an unusual bypass. So I'm going to talk about now just evolving the craft. You know, how do we keep this moving forward? And I'm going to talk about ICA bypass. I'm going to talk about anterocerebral artery bypass. I'm going to talk about fourth generation bypass, and I'll finish with the middle communicating artery. So when I wrote 7 bypasses, I really didn't even talk about ICA bypass because the other 4 territories were so much more common. But, you know, one of the things that occurred to me was that if there was validity to that framework of 7 bypasses, that I should be able to apply it to anywhere. And the ICA was no exception. So I since have done all 7 bypasses in the ICA territory. This illustration shows you pictures of those. And I'll just show you an example. I'll skip this for now, but here is an example of an ICA thrombotic aneurysm with pressure on the pons. The lady had mass effect. So what she needed was a decompressive operation that eliminated that mass effect. So what we're doing here is a retrosigmoid craniotomy. You're looking at the 7th and 8th nerve. Here's the 5th nerve. And our aneurysm is right in this infratrigeminal triangle that is showing that ICA aneurysm. This is the vertebral artery. And here what we have is the ICA and the pica, which come together in parallel. So the ICA and the pica can be brought together with this side-to-side anastomosis so that pica becomes the donor, ICA becomes the recipient. And the intention here is to use that bypass to then revascularize the ICA territory and then trap the aneurysm. So this is our first stitch going in. This brings ICA here together with pica over here. This is our second anchoring suture on the other end of the arteriotomies. Here's an entrance stitch that brings those two together, or brings the needle inside. And now we can run that interluminal suture line inside the artery once again. So this is an interluminal technique. We run it all the way to the other side. We perform an exit suture. We can tie it down, and there's a view of the inside of the artery. Now we can do that second suture line, which is extraluminal. And this completes the anastomosis. So at this stage, we've got ICA connected to pica so that we can now do the real portion of the operation, which is our aneurysm trapping. So here now is the overview. There's our bypass. And now we can go up here. This is now a view of the aneurysm. Here's ICA coming out the distal end. This is the 6th nerve draped over the shoulder of ICA. This is the 7th and 8th nerve complex. This first clip will be a distal clip that closes the outflow. Now we turn our attention to the inflow and going above the 7th and 8th nerve into this infratrigeminal triangle. You can see the basilar trunk. If you look right here in this corner here, you'll see just a little bit of a stump of the ICA right there for our proximal clip. This allows our trapping clip to go in there. And now the aneurysm is completely isolated. So we've got the aneurysm trapped. There's no longer any flow. And now I can go in, I can open the aneurysm, and I can do a thrombectomy and take the mass effect off of the pons. So here now is the final overview. You can see our bypass down in this space here. You can see our trapping up here. It's all a simple retrosigmoid craniotomy. And now with the icy green, what you're going to see is the flow going from our communication here upward to all the perforators to the pons with this simple bypass. So another example for an ICA bypass is just this one. I'll show you a brief clip here. This was a mycotic aneurysm, distally located on ICA. You could do an occipital artery to ICA bypass for this, but I wanted to do something different. So I'm going to excise this aneurysm here, which you see, and I'm going to do an end-to-end reanastomosis. So our trapping clips go on. We can excise the mycotic tissue here. And because there was some redundancy in the arteries, there was enough room to bring them together end to end. So the pathology is coming out here. You can see how deep this is. This is the 7th and 8th nerve. The 6th nerve is right here. And so this is literally all the way down at the level of the 6th nerve. So I'm just going to jump ahead here. You can see the vessels coming together here. At the end, our clips come off. And here, final clip comes off. You see good flow in the ICA as it courses here. And so we've got this nice ICA reconstruction. Looking at our postoperative angiogram, you can't even tell that there was ever an aneurysm there. And it just goes to show the depth to which you can perform these kinds of IC bypasses. So moving on to the anterocerebral artery territory, the ACA territory is one that I didn't do a lot of bypasses early in my career. You can see in 2015, we published this paper. It was 10 ACA bypasses, and you can see the different types of bypasses. Well, in the years that followed that paper, you can see that we more than doubled the number. We went from 10 to 23. And this table just shows you all the new variations of the bypasses in that territory. And as an example, here are some of the in situ variations. Because the pericallosal and callosal marginal and A3 segments are right next to one another, you can bring them together in a variety of different ways. You can do callosal marginal to callosal marginal. You can do A3 to A3. You can do pericallosal to pericallosal. You can do both in the form of a double bypass here. So a lot of different in situ options. Here's some pictures of some of those different combinations. Here's the callosal marginal to callosal marginal. Here's the A3 to callosal marginal with a little bit of size mismatch that you can compensate nicely for. But you see the many different ways that you can bring together these vessels. Here is the reimplantation technique. Once again, because they're side by side, you can cut the artery off one side, swing it over to the other side, and do a nice reimplantation. You can see pericallosal to pericallosal. You can see callosal marginal to callosal marginal. And over here, you can see callosal marginal to pericallosal. So really kind of a vertical move or reimplantation. So here's some pictures of that. Here's a giant or near giant aneurysm. The artery gets cut off. It gets reimplanted on the opposite side. And we have a nice construct. I showed you in that earlier case, the use of the A1 as a donor site. It's a phenomenal donor because, as you can see here, it's large in caliber. The ACOM allows for its temporary occlusion without any ischemic ramifications, and it becomes this beautiful donor. This is yet another one of those cases. I won't show you the whole thing. I'll just show you the use of this A1 as the donor. Here's just another example of how it is a very deep bypass. You're all the way down at the optic nerve, optic chiasm, but you can see it's a very nice donor vessel. It allows you to use the base of the Sylvian fissure as your working space for your donor, rather than cutting down to the neck and bringing in another site. Here's an example of that A1 as a donor site. This is a giant ACOM. You can see it's mainly thrombus within this aneurysm. Here we see the fact that it's got this small luminal component, mainly thrombus. Angiogram and 3D reconstructed angiogram. You can see that. And so here for this one, what we're going to do is we're going to do what I call a squeeze play. We're going to do both a bifrontal craniotomy and this standard pterional craniotomy all in one. And by doing the two in one, we can bring this together. So what we're going to do, this is the anatomy of this aneurysm with an A1 inflow, an ACOM, and the outflow through the A2s. In order to deconstruct this, we're going to have to put in a bypass to reconstruct our inflow. That's going to be an M2 to A2 bypass. We're going to reconstruct the ACOM with an A3 to A3 in situ bypass. And then we're going to have our outflow vessels be the A3 segments rather than the A2s. So here's what that schematic looks like. Here's the bypass code for the bypass, showing our code up here in this alphanumeric string. And this is the case. So here is the view down the Sylvian fissure. As we do our squeeze play, you see that we've got our inner hemispheric fissure exposed here for the ACA bypass. And we've also got our Sylvian fissure exposed. So here is just the A3 to A3 portion of the bypass. These are the pericallosal vessels that come together nicely. Our clips go on. We make our linear arteriotomies. We can do that intraluminal suture line here. Very nice tissues here to work with in this gentleman. And we essentially are relocating our ACOM here distally in the inner hemispheric fissure. So this is our icy green showing good flow. And now we turn our attention down to the aneurysm. Here's the A1 coming in. Here's the recurrent artery of Hübner in between. And this is the A2 coming out. Our aneurysm is all the way back in here. So this is not one that would be easy to clip. It would require thrombectomy. It would require a very difficult clip reconstruction. So here we're completing our bypass. This is now the A2 recipient site as it leaves the aneurysm. Here's our graft coming in, and we can sew in that artery here. This is our suture technique. So a thick radial artery graft, we finish that up. Here's the other suture line here. And now as we complete this, we now can run the graft to the Sylvian fissure. So here now is the M2. This is going to be our donor site. Once again, it's going to be an intraluminal suture technique. So I'm sewing inside both of these two arteries, running continuous suture, which I like because it's quicker. This allows us to shorten the graft. We complete that, bring the other artery wall together here. And now we've got the other end of our interposition graft done. So this completes the M2 to A2 bypass. We can come off with our clips. And now you see the completed bypass here. And now what I'm going to show you is the indocyanine green run. And the important thing here is to look at the recurrent artery of Hübner, because here we're going to trap our ACOM aneurysm complex with a clip on the distal A1, a second clip on the proximal A2 to keep the flow from the bypass going into the aneurysm. And that's going to force the flow through the bypass and around to the A3 bypass and then down to the other side. And in between them is the recurrent artery of Hübner. The only way for that to fill is through our bypass circuit, which goes over the top and around the other side. So there's the overview. And if you look here at the IC green, and if you look very carefully right in between here at my arrow, you can see the recurrent artery of Hübner filling very nicely, which means that our circuit is intact and our flow has been replaced by the bypass. So here's what it looks like. Here's our purple interposition bypass from the from the M2 to the A2. Flow goes up the A2 through the A3 bypass and down and around to the other side. And in the meantime, continues to supply the territory distally. So we've reconstructed the entire ACA territory. We've isolated the aneurysm, and the aneurysm is completely gone. There are other ACA bypasses. These are some examples. This is the azygous bypass, a similar idea where you've got an interposition graft that donates blood flow, and you've got 2 reimplants distally to supply all of the outflow vessels. So this is just a little illustration that summarizes the 10 bypasses done early in my career, all the different variations done since, and again, using our blueprints and our codes for the variations of these techniques. Now, the next thing I want to talk about is this idea of the 4th generation bypass. And that case I showed you early on was a nice example of that. Here is that case. This first anastomosis, you could view this as a reimplantation, but if you think about most reimplantations, those are end-to-side anastomoses, and yet we did a side-to-side reimplantation. So it raises the question, what is this? Is this really a reimplantation, or is this an in situ bypass? The same could be said of the other end of that bypass. You can see that it was sewn with that intraluminal technique. So is it an in situ bypass, or is it a reimplantation? Well, what this case demonstrates is how we're kind of blurring the lines between our usual way of thinking about these bypasses. And if we think about these as different, as their own separate entity, what I call the 4th generation bypass, then we can think about them in a different way. The type 4A bypass is a conventional construct sewn in a different way. So this is that intraluminal end-to-side anastomosis, as you can see in this picture. That would be a type 4A. A type 4B would be an unconventional construct. It would be that side-to-side reimplantation, where instead of using an end-to-side, we're using a side-to-side. And so that first anastomosis becomes a type 4B. So we have a new way of thinking about our constructs. And when we do that, we can take our 7 bypasses, and we see that there are different options within each of these intracranial techniques. And so we're expanding the way that we think about bypass surgery and opening up new options. So I'll show you some examples of that. This first example is an example of reanastomosis. And you can do a reanastomosis with the simple 3rd generation way, which is to excise the aneurysm and bring the ends together with an end-to-end. You can also do it in a type 4A way. This is the 4th generation, where if the vessels can't mobilize to sew around the circumference of the artery, then you can do this intraluminal technique. And it's a different technique, same anastomosis, but it becomes a 4A. And then this type 4B is when you use a completely different type of anastomosis. So here's an example. This is a pica dissecting aneurysm. And you can see the aneurysm here. And the traditional way would be to just trap the aneurysm and bring these ends together. But if you look really carefully, what I found on this case was that there were a lot of perforators right around this segment, which I didn't want to move. You can see them in here. And so rather than move the aneurysm and jeopardize these perforators, I'm going to do an end-to-side reanastomosis rather than your traditional end-to-end. So I've cut the stump of the pica. I'm going to drop it down to this distal pica, and I'll just quickly go to the end here. You can see how we're doing this reanastomosis here. Instead of an end-to-end way, we're doing it with an end-to-side. So you can see it's a variation in the type of construct. So it makes this a type 4B, and it achieves the same end. You can see good flow in the pica on the other side of this anastomosis, and we leave the aneurysm and its perforators isolated here, but with those perforators intact. I'm going to show you this one here. This is an example of a middle communicating artery. So for this one, what we have here is a very dolichoectatic middle cerebral artery bifurcation aneurysm. There's actually a trifurcation here with two trunks coming out the back and one trunk coming out the front. The first step is just a simple double barrel MCA bypass using the temporal arteries. And then here's the key. Once the double barrel bypass is in place, we can free these stumps of the trunks, we can bring them together, and this creates our middle communicating artery right here. What that allows is for the bypasses to then redistribute their flow as needed through the communicating artery. So these are just the STA-MCA bypasses. There's nothing fancy about this portion of the case. But as we bring these together, what you see is the recipients are huge, the donors are quite small, and it would be helpful to then allow the flow to decide for itself how it's going to redistribute itself. So here, once the two bypasses are in, we see good patency. We can now trap the aneurysm proximally. These are our trapping clips going on. And once those are in place, we can now cut these trunks off of the aneurysm. Here's one trunk, here's the other trunk. We can cut those both off of the aneurysm, and now we can bring them together with an end-to-end reimplantation. So we're doing an end-to-end reimplantation of one of the trunks onto the other of the two trunks. You can also see it's an intraluminal suture line, so it's a type 4A in addition to a type 4B. But this creates our middle communicating artery, and it allows each of these two bypasses here, each of these two temporal arteries, to now fill the middle cerebral territory, and the flow can go in whatever direction it wants. This is our MCOM. This is our flow pattern. You can see the two bypasses feeding into it, and that flow can go in any direction that it wants. And this patient did very well, it's a nice construct. Here's another example. This is another MCOM. This uses the A1 as, oops, this is the one I've already shown you. Let me show you this one. This uses the A1 as the donor vessel. So here's the aneurysm, very dysmorphic bifurcation aneurysm. And here's the angiography. And in this next sequence, the animation, you'll see how this comes together. We're going to use the A1 over here as our donor vessel. We'll trap the aneurysm distally. Here's the graft from A1 to M2. And once the aneurysm is trapped, we can create our middle communicating right there. So here's an overview of the aneurysm. You can see one trunk here. You can see the inflow here coming to the aneurysm. Here's the other trunk coming out of the aneurysm. And now we're doing our A1 anastomosis. So this is our donor site. This is our recipient site over on the M2, which I've just shown you the completed product. So now we've got our bypass in place. And now we can transect each of those two trunks off of the aneurysm. We can then bring them together end to end. So this is, again, an end-to-end reimplantation. You can see how friable these arteries are. And I think the trick for this particular case was just bringing these arteries together. There's a little bit of tension on the arteries. Here the aneurysm is cut free. We've got our two stumps over here, and we've got to work those ends together with our first suture. But let me move this along here. This completes the anastomosis. You can see right there our completed anastomosis. Here's our icy green showing our flow. And this really nicely reconstructs the bifurcation with this intracranial jump graft. So here, once again, the overview, and here we can see the construct at the end. So these are the examples of the middle communicating artery. Here is that double barrel with the MCOM here. This was the A1 donor site here with the end-to-end reimplantation over here. This is the construction of the code, bringing all those different elements together. And you can see here, these are the alphanumerics here. So if you were a computer science engineer and you were designing code for these bypasses, this is your code. And that explains everything that you would need to do. So I've talked about ICA bypass. I've talked about ACA bypass. I've talked about 4th generation bypass. I've talked about middle communicating artery bypass. These are all examples of how we can take a craft, a piece of our practice, and push it further. I think the way that this continues onward is to continue to imagine new bypasses. This is a table that just has a list of things that I've thought of doing. I haven't actually done all these, but these are on the list of things to try and to see if they can provide a good solution for a particular aneurysm. Before we do these in real live patients, we go to the lab, we try them out in cadavers. We see if we've got the exposure. We see if the arteries have the stretch to reach their targets, and we try it and we see. I call these the dream bypasses because these are things that we can dream up and then take to the operating room. So here's an example of one of those cases. Sometimes the variant anatomy just gives you an opportunity that you can take advantage of. And in this particular case, what we see here is a dual origin pica with one extradural origin here and one interdural origin here. They come together and the aneurysm is downstream. And so for this case, we can take advantage of one of those limbs here as its own natural jump graft. So we can repurpose that limb as a jump graft around this aneurysm and do an end-to-side reimplantation. So here's an example of that. Here's the anatomy. You can see on this animation how the aneurysm is distal to the dual origin. So what we'll do is we'll trap the aneurysm, we'll swing that extracranial origin of pica over to the distal pica, and we'll do an end-to-side reanastomosis. And now we've got a natural reconstruction. So this is the construct that we're going to make. And here it is at surgery. So these are the two picas coming together. This is their confluence here. Our aneurysm is right here. And like with most of these bypass cases, what I like to try and do first is to clip them. It's obviously much quicker and much easier just to clip. But what you see here is that this aneurysm tissue is friable. We've got an intraoperative rupture here. So we have to escalate to the bypass. So our temporary clips go on. As we look at the pathology, it's just a hole in the artery there. So here now is that proximal segment of pica. I'm going to cut it free from the vertebral artery. I'm going to repurpose that, and I'm going to move it over to the distal pica around the backside of the aneurysm. You can see I've fish mouthed the artery, and I'm going to do this end-to-side anastomosis. So I don't need to do any harvest. I don't need to do any occipital artery dissection. I just use that extra vessel there. And you can see at the end here, this end-to-side anastomosis here very nicely reperfuses the distal pica. Here, the aneurysm has been isolated and transected out, and we've got a nice finish. This is another example just showing how we deal with some of these more difficult aneurysms. This is a thrombotic holobasilar aneurysm. And for this one, I did a M2 P2 bypass. I opened up the aneurysm, I gutted it of its thrombus, and took the mass effect away. So here's, I'll just quickly show you this one. This is the transsylvian dissection. We can go all the way down here to the P2. This is an M2 P2 bypass. This is our radial artery graft. So as this goes in, this essentially creates flow to the upper basilar. So here is sewing into the P2 segment with the radial artery. We'll finish that first. Then we'll come up to the MCA. This is the MCA. So this is our donor site in the Sylvian fissure. Our indocyanine green shows we've got a nice flow down to the basilar apex through the graft. And now we can turn our attention to this transcochlear exposure. So this is now going infratentorial through the petrous bone. And as we open the dura, our aneurysm comes into view here. So this is our giant aneurysm. We're going to expose the inflow and the outflow of arteries here. You can see this is the vertebrobasilar junction. So what I'm going to do here, I'm going to use rapid ventricular pacing. So by accelerating the heart rate, you can see the aneurysm softens. We can dissect the sixth nerve off of the front of this aneurysm. We can soften the aneurysm and reduce its flow. And that allows me to place clips on the two vertebral arteries and on the distal basilar artery so that this aneurysm is completely isolated or near completely isolated. I can now open the aneurysm with this incision here. The aneurysm itself is filled with thrombus. So we're going to do a CUSA thrombectomy. And you can see how by getting inside the aneurysm, we have the opportunity to essentially turn this tumor, which is compressing the pons and the brainstem, into an empty sac. You can see here at the very depths, the contralateral ICA is still filling. I haven't been able to reach that, but because of our rapid ventricular pacing, we can minimize that flow. Now the aneurysm folds in on itself. You can see how we can bring the walls together. We can plicate this with our clips. And now we're taking the mass effect out of this aneurysm by closing the aneurysm down again after removing all of the thrombus. So this is basically a brainstem decompression using bypass to do that for us. And here, here at the end, you can see closure of the basilar circulation and replacement with our M2P2 bypass. I wanted to show you one last case. This idea of brainstem compression with large arteries has led to this idea of macrovascular decompression. So in other words, when you have arteries that compress the brainstem like this one of the ways to make patients better and relieve symptoms is to move the artery. And the way that I've come to appreciate doing this best is by pulling the artery forward against the clivus where it naturally belongs. You don't want to pull the artery towards you as you approach it. You want to actually move it back into the position where it started. And so to do that, I find this lasso to be really nice. You can anchor that to the clival dura with an aneurysm clip, feeding the tail of the lasso through the clip and securing it to the clival dura. And that's one way to deal with these aneurysms. But I wanted to show you this case, which involves bypass. And in this one, we have so much redundant artery here that moving the artery is not going to be sufficient. So what we're going to do is what we call a binder ring bypass. And so here, as we come on this artery, you can see this redundant tissue is impinging on the nerve. And so just moving the artery forward is not going to be enough here. So what we're going to do is we're going to transect the artery after we trap it. This redundant artery is all V4 vertebral artery. So we can transect the artery. We can reroute it on the outside of the 7th and 8th nerve complex. So here the ends of the artery now are being fed on the outside, and we can bring them back together here lateral to the nerve bundle. And we can essentially do an end-to-end reanastomosis here. So this is an end-to-end reconstruction, but now the artery is on the outside of the 7th and 8th nerve complex. So this patient's symptoms are going to get better, did get better, because there's no longer any nerve compression. The artery is rerouted outside of the nerve and the nerve is freed. So we're sewing this together with this intraluminal suture line on the back wall, the extraluminal suture line here on the front wall. And you can see how this nicely reconstructs itself. The nerve bundle is now inside the vascular loop. We can come off with our clips. And now we've eliminated the vascular compression. This is the vertebrobasilar junction. This is the end-to-end reanastomosis. And this patient's symptoms resolved completely. So it's an example of how you can achieve a macrovascular decompression using bypass technique. So I'm going to finish here now. I just want to show you a few more slides for some closing thoughts. I showed you this graph at the very beginning of my talk. This is a graph that is very depressing, very discouraging for those of us who love doing aneurysm surgery. But if you look at these graphs here, one of these curves, the green line here is the bypass curve. And you can see that's a very healthy curve. This line is going up, not down. So there is cause for hope. You know, I hope what this lecture has impressed upon you is that we don't need high technology. We don't need fancy gadgets. We can do so much just with simple suture and our own creativity. And that's really what I love about bypass surgery. It's a manual craft. And if we just use our heads and we be creative, we can really expand the field and promote this evolution. I like to think of it as hands, head, and heart. You know, this is tough surgery. It requires a lot of dexterity and technical skill. I think all of us need to appreciate that it's difficult work and you don't want to jump into something like this. But it's also important to recognize that it's a very heady surgery. You have to think through your strategy. You have to be creative. Some of these tools like the blueprint symbols and the alphanumerics allow you to work through some of that strategy and be creative and capture those ideas as you go. And lastly, you know, it really takes heart. These are tough cases. They don't always go as well as you would like them to, and it really demands perfection. So I think we all need to strive for that perfection and work hard at this. So with that, I'm going to stop. These are my concluding thoughts. Juha, thank you so much for having me here, and I really appreciate seeing you and being part of this series that you've created.
Thank you very much, Michael. Wonderful lecture, wonderful skills. Before giving the word to Subin, I will quote Francis Bacon, the politician and writer 400 years ago. Every man owes it as a debt to his profession to put on record whatever done that might be used to others. And this is very important, what you told in the beginning of the lecture, writing down your experience. This is extremely important. I feel so pity here in China that the great skills are not written down and published. And I try to promote and encourage Chinese neurosurgeons to publish with minimal results until now, but I hope they will publish the huge series here. So I hope Subin will encourage them. And now I give the word to Subin to speak about the bypass lecture. Please go ahead. Thank you very much, Michael.
Thank you, Professor Lawton. I really enjoy your presentation, and I learned a lot from your presentation. So just as you mentioned, actually, tonight, I think there were 2,000 audience watched your presentation. So actually, a huge star in China, you know, Professor Juha, and in last weekend in the Chinese Congress of Neurosurgical Congress, we have a right clipping competition in the young neurosurgeons. and the top 7, the top 10, maybe 5 of them, they use the bypass technique in reconstruct the vessels. Actually, a lot of them quoted your books. So
good. I'm happy to hear that. Well,
yeah.
I think Juha emphasized a very good point. We learn and we get our inspiration through all the cases we do, and I'm so envious of the volume that the Chinese neurosurgical community has. It must be a remarkable stimulus to come up with new ideas and to write great papers. You and I have often joked. You do more bypasses in 1 year than I do in 20 years. So I've always been jealous of the volume that you have and the opportunity that you have there in Shanghai to do great work and so many bypasses.
Thank you. Actually, I'm the hybrid neurosurgeon, so I also do the interventional treatment. So most of the posterior circulation aneurysms, we use interventional treatment. So I don't have so many experience in the posterior aneurysms to use a bypass technique. I have a question about you, because in my mind, I think the M1 to M2 segment giant aneurysm is maybe the most difficult ones, because some perforators, if you use a proximal occlusion or distal occlusion, actually you couldn't make sure to keep the patency of the small perforators. So what's your strategy to keep this kind of small perforators patent in treat these giant aneurysms?
Yeah, I agree with you. The M1 aneurysm is a very difficult one to do, because there are a couple of spots on the circulation that have these vital perforators that don't tolerate temporary occlusion. The M1 is one of those. The P1 is another one of those. These are territories where you simply cannot take the 20 minutes for a bypass anastomosis and get away with it in many cases. So I've done very few M1 bypasses. I have one here I can show you, but it was an M1 to M2 bypass. But in that case, I first did an STA-MCA bypass. I vascularized one of the distal trunks with the STA, very much like Tanakawa does. And then I put in my interposition graft, and the STA bypass provided some protection as I was sewing in the proximal end of that radial artery to the M1. It was an end-to-end anastomosis. And I think you really do have to be protective of those little perforators, those end arteries that don't have any collateral supply. So I tend to do my bypasses away from those areas. I think you noticed in my talk, I put my MCA bypasses out at the M2 segments, really not at the M1 segment. The one exception to that that I allow myself is the A1. And you saw that repeatedly. I showed a couple of those cases. The A1 does have these delicate perforators, but they go to the anteperforate substance, and it's essentially the globus pallidus and the innominate substantia innominata of the frontal lobe. So if there's maybe one trapped perforator, you can reperfuse it, and it clinically has not been a relevant problem. I haven't even seen infarcts from the temporary occlusion, but I don't think that's the case with the lenticular striates, because those go to the internal capsule and more eloquent areas.
Yes, thank you. So I noticed that in some vessels, there's some atherosclerotic plaque on the vessel wall. But I noticed that maybe you don't care this break and still do the bypass directly. So do you have some special treatment for this kind of break?
Yeah, I think a little bit of plaque is okay. There's always going to be some atherosclerotic change that is okay that you can sew through, but there are others where the plaque is so thick that you first have to do an endarterectomy. I have one beautiful case where I was using the V3 segment as a donor, and I incised the artery. I did my arteriotomy, and there was so much plaque that I had to endarterectomize the vert before sewing in the graft. So I would say that if the plaque looks ugly enough that you need an endarterectomy first, you can do that. I worry though, because if you roughen up the edges with an endarterectomy, it could compromise patency of the graft. So I think you have to choose it carefully. If there's a choice that can be made and you can select your anastomosis site away from plaque, then I think that's worthwhile. But I think the case that stuck in your mind was that A2 anastomosis. And in that case, you really have one shot. There's only one place you can go. And if there's plaque there, you just have to go there.
Great, thank you. So I think it's a very useful technique to make a M2 intercommunicating stoma. So, but I think this is very useful for different size of the donor artery. For example, if the one branch is much bigger than the another one, so they can distribute the blood flow into the intercommunicating artery you created. So, but how about the if the size and the is similar, is it still necessary to create this intercommunicate at the stoma?
Yeah, that's a good question. I think if there was good caliber matching between the donor and the recipients, and you felt like each of the two SGAs was sufficient to supply the trunk, then you probably don't need it. But here's the beauty of it. There's no ischemia time in doing that end-to-end anastomosis. You've already put in the bypasses, and they're doing their thing while you're sewing. So there's no ischemia. So there's really no price that you pay by simply bringing them together. And if there is a benefit, then you gain the benefit without any risk. So that was that's one of the things that goes through my mind in doing that bypass. Is there a risk? Is there a price to pay for the patient? And in this case, the answer is no. So why not just do it? So that's the nice thing. But do you have to do it? No, you don't have to do it. In some cases, you do have to do it, like that recurrent aneurysm. You really do need to create that communicating artery to get the flow from the high flow graft over to the other trunk. So there you need the communication to make that work. But in the double barrel example, you don't need that necessarily.
Yeah, I noticed that you when you make the stoma, actually in some even end to side, you use some intraluminal stitching technique.
Yeah.
So is this because of the depth of the surgical field and or other some special consideration?
What I noticed is when you have the traditional technique, you usually sew one side and then you flop the artery over in the other direction to sew the other. So you need a lot of movement of the graft like this. And what that means is that your graft ends up being much longer than it would otherwise. If you just could leave the graft in one spot, you could shorten it and make it really, really snug, and then do all of your sewing from the inside and the outside. So the advantage of that technique is it takes a graft that maybe is this long and allows it to be this long without the need for that movement. And then it's a much cleaner graft, which I think will ultimately stay open with a higher percentage.
Okay, great. Thank you.
Okay, Manuel Encarnacion, you have a comment or question? Manuel?
Yes. Hello, John. Hello. Thank you.
Yes.
First of all, it's a great honor, Professor Lawton. It's a great honor. Thank you. My name is Manuel Encarnacion. I am from Dominican Republic, but I am making my residency program in Moscow. My question is about the learning curve in the bypass technique, because in my country, in Dominican Republic, nobody's doing that. So which way you think is the best way to decrease the learning curve? Because I practice with rats or chicken wing. So after that, because it's not the anatomy is not the same anatomy, we create a device, a model, a brain model with the vessels, since the superficial temporal artery, the skin, the full skull, the brain, and the Willis sulcus, all in one real size, to try to decrease the learning curve. So what do you think about the models for try to learn bypass?
Yeah, well, so here's my answer. It's very simple. Bypass is one of those things that you can learn in the lab, and you can develop your skills to a very high level without ever having to do a real surgery on a patient. I can tell you from experience, when I was a resident, I did my research year doing carotid to jugular fistulas for venous hypertension for a dural AVM model. And I learned my bypass skills there before I ever did a bypass on a real patient. So I think you can take your skills to a very high level just by practicing on rats and in chickens, like you had mentioned. We created a product that's not yet commercially available, but it basically is every case in 7 bypasses in the book. Not every case, but representative cases, we made physical models. So you can actually do the same case that I did and showed in the book in the model, because we have the computer studies from the patients, and we've built with 3D printers the same configurations, and you can test yourself. You can put yourself in the exact same position that I was in when I sewed that particular bypass on page 200, and you can essentially test yourself with the same confines. And I think there are opportunities like that to really simulate the surgery so beautifully in a lab setting and allow yourself to get through the learning curve quickly. It's not the same for aneurysms or AVMs. There is no substitute for actually doing the dissection and dissecting out an AVM or tackling the bleeding problems. There you really have to have the live patient. But for bypass, the actual 20 minutes that you spend sewing that anastomosis is the same whether you're in the lab or in the patient.
I would like to show you or send to you one of the models, and you can give your opinion, because I already sent one to Professor Juha, but have some problem with the delivery, and see your opinion. Because we make a bleeding skin, we call it bleeding skin, in the skin of our model. If you make the incision, you're gonna have the superficial temporal artery, and you can make the bypass from the superficial temporal artery to cerebral medial artery.
Very good. Juha, do you have any comments?
Okay. Yeah, if there is in audiences some questions or comments to Michael.
Yeah, I think Natalie has a comment. Natalie, go ahead, Natalie.
Good morning. Thank you, Dr. Lawton. Amazing lecture. I have 3 questions. The first one is, what is the protocol that you in preoperative time, intraoperative, and postoperative time? Respect about the use of aspirin, heparin, or other medicines that can help you. The second one is, what is the technical things that you think that can be the reason of the failure of a bypass that we can prevent. And the third one is if you, in the first time when you was starting your career, you have failed with bypass and what was the conduct that you did. For example, or reopen the anastomosis or change the plan and do other connection, other bypass. Sorry for my English. Thank you.
Yeah. So the first question about what do I do medically to prevent thrombosis? Well, I do not heparinize patients. I think that's too much. I don't give aspirin in advance because I like the platelets to help me seal the bypass. I immediately start aspirin postoperatively and for life thereafter. So I do just really rely on the aspirin. I've had 2 tough cases this year where, despite doing perfect surgery and the bypass was initially fine, I struggled on both cases to keep the bypass open. And I think there are probably a handful of patients out there that have some abnormal clotting disorder that doesn't show up on the normal PT-PTT or doesn't show up on the normal tests. And I think doing these TAG studies might be a way to identify the troublesome patients in advance. So that's something that we've started to do. I think your question about troubleshooting the bypass is a difficult one because, if you do bypass surgery, you will inevitably have complications where you finish and the bypass isn't flowing and you've got to troubleshoot it. And there's so many different tricks to troubleshoot the bypass. Sometimes you get just a little platelet aggregation, a little white plug is what I call it. And the white plugs can be broken apart and freed from the suture line, and you can simply save it by physically manipulating that. There are other cases where the white plug turns into a red plug with clot formation, and there's just simply no way you're going to salvage that without redoing the bypass. There are ways to take it down partially. There are ways to take it down completely. And I think it really depends on what you're dealing with, and you just got to work your way through that. I think it's a whole nother topic. I could give almost another lecture on that, but there's a lot of discussion of that in 7 bypasses if you want to read some details. But I think those are the real critical moments. When everything goes well, it's easy to feel great about bypass surgery, but I think you have to be prepared for those moments where it doesn't go well and you've got to troubleshoot, or even worse, if you're struggling to just sew the anastomosis in, particularly on a deep bypass, you make a commitment. As soon as you cut into those arteries and as soon as you initiate the process, you've committed yourself, and you've got to fight your way through the whole process of suturing the anastomosis and completing it and getting to the finish line.
Dr. Gupta?
Good evening, sir. So there's no question. I just was finding time for my moment to congratulate Dr. Lawton, sir, on his achievement of 5,000 aneurysms clipping. That is very inspiring to us.
Thank you. Thank you for saying that. I appreciate it.
Thank you.
Okay, Juha, Michael's starting his day here. So do you want to wrap it up?
Thank you very much, Michael. It was a wonderful lecture and we enjoyed very much. We learned very much, like Subin was saying, so we certainly learned. And this is extremely high level of microneurosurgery you are doing. So it is a long way to learn everything what you are telling. And the most important message for the Chinese neurosurgeons, Japanese neurosurgeons, is write down your experience, publish in English. This is very important because when writing down your experience, publishing, it makes you by far better surgeon because you analyze your cases and you will get creative. So I thank you all for a great evening, and have a good day or good night in East. So thank you very much. Bye-bye.
Juha, thank you so much. And congratulations to you for what you're doing, not only with this webinar, but in going to China and teaching and inspiring the Chinese neurosurgical community. My hat goes off to you.
Okay, thanks everybody.
So,
We'll
Lawton,
see you next
last
week.
last question.
Oh, okay, go ahead.
For,
go ahead. Go ahead.
Okay. My Chinese colleague, they are discussing in the WeChat. They said that the MVD, the bypass technique used in the MVD is a very creative technique. And how many cases do you treat in this?
Very
MVD?
few.
Very few.
The bypass option for macrovascular decompression is what I call a treatment of last resort. So microvascular decompression, you can pad the nerve. Macrovascular decompression, the sling is the go-to, and the bypass is really only when everything else fails. So very few cases. We're publishing that that concept, but you know, we're very clear when we publish that that it's really for a last resort, because if you lose an artery, it's difficult. It's a big risk to take, so you just have to use it only when all other things fail.
So do you use some blue occlusion test to make sure that your temporal clip couldn't cause some deficit?
So in that case, the compression was at the V4, from the V4 segment. It was not from the basilar. And so the contralateral vertebral artery was sufficient to carry the flow during the occlusion time. So you need to make sure that that's present. If that were a basilar occlusion, then you would need an occlusion test to be sure.
Okay, thank you again.
You're welcome.
Okay, very good.
Thank you for your fantastic presentation. Bye-bye.
Great to see you.
Yeah, thanks for all the thanks for the translation, and thanks for Takashi. Thank you for Japanese translation.
Thank you. Michael Lawton, so very informative lectures. We use simply SDMCA and SCA and OA pica, but a new type of your bypass procedure is very informative, and we learn a lot about it. Thank you so much.
Okay, okay, we'll see you next week, everybody. Thank you.
Thank you. Thank you very much.
Thank you. Bye-bye.
Very good. Okay, we got it. Very good, Juha. Hello, Victor.
So, hello, how are you?
Good, how you been?
It has gone. Bin and Juha has gone.
Yeah. Well, Juha left already, I think.
Yeah. Impressive technique, impressive surgical procedure. It's
really?
not easy to make a surgery like that. Very difficult, I think so. You need too many support, technical support, and too much exercise, too much work in the lab.
Really? So a lot of neurosurgeons don't do that, don't do bypass. It's really very technically demanding.
Yes.
Yeah, I'm not a neurosurgeon, but that suturing is pretty fine. But you do that in all operations, right? You neurosurgeons do all that type of suturing, right? Yeah, we are on YouTube. You are responsible. Does anybody want to say hi to Victor or anybody else? This is a good time to network. Oh, let me show you, Victor. We have and Ben is coming to this webinar. This is my time. I've got a captive audience. Let me get the banner up here. No, that's not it. IPE is giving it. That's banners, lefty lines. I'll get it. I'll get it. Oof. Okay. Oh, here we go. Here we go. Okay, here it is, Victor. I got it. Yeah, you can. It's at a good time for you too, I think. And anybody in the panel can come to this. Sri Lanka tomorrow at 4 o'clock India. You see it, Victor?
Yes.
Yeah, at 4 o'clock India time. And as you can see, Victor Ipe is going to comment, and Ben is going to come too tomorrow.
Ooh.
So that's nice of him to come to that. Let's see, Mexico time, that would be pretty early. Let's see, it's 4, 5, 7 o'clock. It would be 6 o'clock your time, Victor.
6 o'clock. Yes, I
Yeah,
will. Yes.
which it's not early for you, right?
I'll be there. No problem.
Okay. Okay, good.
Thank you.
Yeah, they're going to compare. Well, eventually they want to start a series of comparing what a neurosurgical problem looks like in the third world as opposed to the first world, how differently they treat it. If you have a lot of expensive instruments, and if you don't, do you know what I'm saying, Victor?
Yeah, yeah.
Yeah, just compare that was his idea, to try to do that, to get, given a problem, okay, you have all these machines, what do you do? And you say to another, the same neurosurgeon or different neurosurgeon, okay, you have this problem and you don't have much resources, what do you do? How do you treat that problem? So that should be interesting. Okay, anybody else want to meet Victor? There's a chance to meet a world famous anatomist. Natalie, are you still there, Natalie? It sounds like she's from Latin America.
Yes.
Hey, Natalie, have you met Victor from Mexico City?
Yes, I know him for lectures and things like that.
Oh, okay. Now you get to, Victor, they got to see you in the flesh. Well, not the flesh, but almost the flesh. Some electron.
I was resident in Juarez Hospital.
Are you doing a residence in Juarez Hospital, Natalie?
I was resident there. Now I am neurosurgeon. Now I am in the ENN. I did school-based fellowship in the last year, and now I am doing vascular fellowship with Dr. Natal.
Oh, good.
Where are you at? Where are you at, Natalie?
I am from Ecuador, but now I am living in Mexico for my studies.
Where? Africa?
Ecuador.
Oh, Ecuador. Okay. Bienvenidos.
Thanks.
Gusto en verte, Natalie.
Muchas gracias y gracias por mandar el link. Por eso me conecté. Gracias.
A la orden. Okay, John.
Yeah, Victor, Teneva. Okay, let me show more. We have Natalie. We have an Ecuador presentation today. Later, let me show you that. Okay. Once again, I'm never.
Yes,
prepared.
with Dr. Juan Luis Gomez Amador and Sebastian.
Oh, yeah, with
yes,
Dr. Salazar. Did you see that one?
Yes, I saw that.
Okay, let me show the audience and maybe other people interested in that. It's in español. Yo voy a mostrar que tenemos. Okay, aquí está. Okay, déjame compartir mi pantalla. Okay. Que son dos charlas, ok. Tú puedes ver déjame ver, a las 8 tiempo Ecuador, Natalie. En
Thank you.
Miami está 9. ¿Tú puedes ver, Víctor?
Sí, sí,
Sí,
por supuesto.
tú conoces a todas estas personas, yo
Sí,
sé.
claro, claro.
Sí, ok. ¿Y qué más hoy? Y mañana Morocco. Oh, tú puedes ver el sitio, mi página de Facebook, para ver. Entonces, ok, es verdad, ok.
Too many lectures, Dr. John Bennett.
Sí,
You are very busy.
sí, pero es bueno, mucha adrenalina y mucho café cubano.
Hello, Redab.
Tú conoces Vidal, ¿verdad?
Yeah.
Hello, Dr. Victor. Hello.
Well, see, you just gave she just gave a talk, and that was for based in Cairo, right? Based in neurosurgery, based in Cairo with the cons, and ACNS with Dr. Kato.
Right. Yeah, it was an African Asian collaboration with Dr. Professor Nasser and Professor Ayuko Kato and other more African other figures like the Japanese Professor Kato and Professor Guto.
So Victor,
yeah.
she's making the circuit.
No.
She's making the talk show circuit now. Like you do a work of art, then you go on the talk shows to talk about it, right?
Actually, I was honored to be invited to have a talk. Like they give me a talk every couple months.
Oh, really? You've been preparing that long, huh?
What?
You said you've been preparing for a couple of months?
No. They invite me to have a talk every couple of months.
Oh, okay.
It was a very nice lecture.
Oh, there's Dr. Sherman.
Yes, I was listening to two different congresses, one on the phone and one on the tablet. It was quite invigorating.
Yeah,
it was a very nice lecture on AVMs. Thank you so much.
Yeah, thank you, Miriam. Thank you.
Dr. Sherman, where are you from?
I'm originally a Yemenite born in Kenya, and I decided to take my studies up to Germany and learn from the Germans. And now I'm very happy to have webinars and a lot of sessions online, and you could meet top doctors and learn from them. So I try to cover as much as I can, and hopefully one day we'll go back to Kenya.
Great. We have lots of webinars, so just follow. You probably get emails, right? About
Oh, I do, and I'm looking forward to more emails.
Well, I'm sorry to send so many, but you know, I'm trying to fix the emails now and put them all the emails in one account. I had a couple of accounts, and I think some people were in both, so they get emails, double emails. You know what I mean? So I'm trying to simplify it to make it more efficient. But
the only thing is that most of the lectures are interconnected with the times, so it's a bit difficult to have both of them. I hope you're recording them, some of them at least.
Well, yeah, they're all archived, but I think eventually people will learn that it's sometimes best to do a broadcast at a time what's not busy. Do you know what I mean? They'll say, "Oh, Thursday night, there's not many shows. I'm going to do one Thursday." So I'm mentioning that to some to say, look, if you're going to get a wider audience, pick a time that's not having 3 or 4 other conferences like Friday or Saturday, you know, and sometimes Sunday. Do you know what I mean,
sometimes
Victor?
the lecture is a little bit late, and due to the time zone, if they're recorded, then we can catch them as well.
Yeah. Well, we're finding out that for me, for what the number of people we're trying to reach, it's best for me to schedule the broadcast early in the morning in America. So that would be 7 or 8 in the morning. So you catch the eastern part of the United States and the people that like to get up early in Texas and Arizona. and you get Kenya and Africa at a decent time, like 1 or 2, and you get India at 5:30, and you get China and Japan at 8 and 9. So that captures a good part of the world if we schedule them in the morning in America. But for others, you got everyone's different. They can pick a time that's not busy. Like Dr. Salazar does that. He does Tuesday night, and there's virtually nothing going on, really. So I think he gets a good audience that way.
John Bennett, I'll see you tomorrow.
Okay, Victor, thank you for coming.
Thank you, everybody. Bye-bye.
Thank you, Doctor.
Okay.
Thank you so
Okay.
much.
Bye-bye.
Adios.
Adios.
Okay, Victor, gracias para venir.
Adios.
Thanks, everybody.
Thanks,
Adios.
everybody.
Dr.
Hasta
Lawton.
mañana.
Thank you.
Hasta mañana.
You.
Hasta mañana.
Takashi, you doing okay? Takashi? Are you there, Takashi? You go ready? Yeah, Takashi translates to Japanese. What do you think of that, Rodab? Did you take off too? Dr. Liao. Geez, no one wants to talk to me. Okay, see you guys later.